said when it comes to embryonic development, we have foregut, midgut, hindgut. Foregut is what? No, what part? Lower third of the esophagus, stomach, and
The liver.
and upper half of the duodenum, right?
Yes.
And then midgut will be
Lower part of
the duodenum, duodenum, ileum, cecum, ascending colon, and 2/3 or some textbooks they say 3/4 of the transverse colon. Let's say 2/3 for now. Okay, and the rest will be the hindgut. And we said we have 3 unpaired arteries coming from the abdominal aorta, one underneath the diaphragm, that is the celiac trunk for foregut, one above the origin of the renal artery, that's the superior mesenteric, it is for the midgut, and one just 2 inches or 4 to 5 centimeters above the bifurcation of the aorta. See this in the lab, that is the inferior mesenteric. Right, there is one small from the back, it's called the median sacral, that goes to the rectum. But these are the 3 main ones. Celiac is for foregut, superior mesenteric is for midgut, and the inferior mesenteric is for hindgut. Now last time we spoke about the celiac trunk. We said it is 3 branches. Left gastric on the lesser curvature, splenic, and from splenic is going to give me what? Short gastric,
Left
and
gastric.
left gastro-omental or epiploic, right?
Yes.
And then we have the main hepatic artery or the common hepatic artery, which is going to divide into one up and one down, right? The one up is the proper hepatic artery, which is this one going to the liver, and it's going to divide into left and right. From the right, what do we have? Cystic artery. In my previous lecture, there was a mistake. I said cystic comes from the right gastric. Of course, it's a mistake. It's coming from the right hepatic. Okay? And where do you find the cystic artery?
Near to the system.
Callus triangle. What is Callus triangle?
It's where you ligate.
What is it? What are the borders of Callus? What are the cystic duct, common hepatic duct, and the border of the liver, right? Right?
Yes.
You know this. Right. So from the common here, or from the hepatic artery proper, we also have another branch. Not only left and right hepatic, we have this
Right
right gastric artery. So common hepatic is going to divide into up and down. The up is the proper hepatic artery. That's going to give us left, right, and right gastroduodenal. While the one that runs behind the first part of the duodenum, it's called the gastroduodenal artery, right? And it is famous because it gets involved in the perforated duodenal ulcer. Now this gastroduodenal artery, after it passes behind the duodenum, it's going to change its name. It becomes the right gastro-epiploic or omental artery. Now before it does that, it's going to have to supply what? The upper half of the duodenum, right? So it's going to give us superior pancreatico-duodenal artery. One anterior and one posterior. Clear?
Yes.
So with this we supplied the foregut. If I tell you I want to remove the stomach, what are the arteries that you need to ligate? You tell me.
The right gastric
Right
artery,
gastric,
the
left gastric,
right and left
short
gastric,
gastric,
right and left
right
gastric.
gastroepiploic, left gastric. If I tell you there is a patient that comes with bleeding on the because of perforated ulcer on the lesser curvature, and you need to ligate the right gastric artery. Okay? What are the other arteries that will supply the stomach? You name them all. Left gastric, short gastric, and whatnot. Okay? Now, we're done with this. Now, let's talk about the superior mesenteric. Guess what will be the first artery that will come out of?
Inferior pancreatic.
We said midgut is what? No, midgut.
Superior.
What are the parts?
Second part.
Lower half of the duodenum, and then duodenum, then ileum, then cecum, then ascending. So the first part you need to supply is
The second.
duodenum. So what are we going to call that branch? Inferior pancreatico-duodenal artery. Done? After the duodenum, what do we have? Duodenum. And then we have, so we will have duodenal and ileal branches. After that, what do we have? Cecum. So we're going to give ileocolic branches. So this is the superior mesenteric. Just behind the neck of the pancreas, underneath the splenic vein, we have the superior mesenteric. It's a huge artery. Right? First artery will come is the inferior pancreatico-duodenal artery, just to supply the lower half of the duodenum. And then we have duodenum, ileum, so we'll have 12 to 15 duodenal and ileal branches. Simple. After that we have cecum, so we will have the ileocecal or ileocolic artery. After that, what do we have?
The ascending.
Ascending is on the right or on the left?
Right.
So we're going to have the right colic artery. And then after that, what do we have? Transverse colon. It's in the middle. So it's going to give us the middle colic artery. Simple. We're done with the superior mesenteric artery. So superior mesenteric artery, the first artery will give us inferior pancreatico-duodenal artery to supply lower half of the duodenum. Then we will have 12 to 15 duodenal and ileal branches. And then we'll have ileocolic. Then we'll have the right colic. Then we will have the middle colic. Right? Done. Now these colic arteries, they will divide into upper and lower, or superior and inferior, or right and left. It does not really matter. Each one of those will divide into two branches. Why? So that they can communicate with each other. They can anastomose with each other. Yani for example, this is the ileocolic, upper and lower. Lower anastomosis with the superior mesenteric artery itself. Upper anastomosis with the one above. This one, middle colic, upper and lower. Lower anastomosis with the ileocolic. Upper anastomosis with the middle colic, and so on. So we're done. Now, lower last 1/3 of the transverse colon and the descending colon, we're going to give it an artery. What we're going to call that?
Left colic.
Left colic. It's on the left side. And then what do we have? Sigmoid. So we're going to have 4 to 5 sigmoidal arteries. And then what do we have? Rectum. We're going to call that the inferior mesenteric artery. After it gives the sigmoidal, it's going to change its name. It becomes the superior rectal artery. Right? Easy. So from the inferior mesenteric, number one branch is we're gonna call it the left colic. Again, it's going to divide into upper and lower. And then we have sigmoidal branches. Upper, lower, upper, lower, upper, lower, and then the superior rectal. What is the idea of dividing each of them into upper and lower? They anastomose with each other. And at the end, you're going to have an artery here along the mesenteric border, all the way from here to down here. On the mesenteric border, we're going to call that the marginal artery of Drummond. This marginal artery is basically results from anastomosis between the branches of the superior mesenteric and inferior mesenteric. Why is this important? Why do you need an artery that connects the two systems? If one artery if we block the superior mesenteric artery,
we can have another part.
The part supplied by superior mesenteric, they will die. So they need blood supply. If they're going to come through the marginal artery from the left. If we block the left, then the descending sigmoid rectum will die. So you need blood that will be coming from the marginal. Then it is receiving branches from the superior mesenteric. Right? Simple. Now, in the exam, again, I'm not gonna. We already answered 3 exam questions, by the way, so far. Now, In the exam, I'm not going to ask you, oh, what are the branches of the left mesenteric artery, inferior mesenteric artery? It's easy. It will be stupid questions, huh? You're going to tell me left sigmoidal, superior rectum? No, right? But I might ask you something like, okay, if I block the inferior mesenteric artery, right? Which one of the arteries that will compensate for that blockage? And I will tell you superior rectal, I will tell you sigmoidal, I will tell you left colic, I will tell you pancreatic duodenal, I will tell you middle colic. Because it's the only branch that is not. So this is what I meant. It's not going to be direct, but it's not going to be difficult. So you need
To think.
to think شوية not here. لا to think كتير يعني you can do that بس يعني later. أيه بس to think a little bit. كويس? And if I tell you something like, okay, if I block the superior mesenteric artery, what are the structures that will be affected? Rectum, descending colon, sigmoid colon, stomach, or the cecum.
Stomach.
Superior mesenteric, ايش علاقة الstomach فيها?
Superior.
The only structure that is supplied by that from all of them, all are left inferior mesenteric except the cecum.
Even if we block the inferior will supply
It will be affected somehow. It's not going to be 100%. Otherwise, نلغيها تماما. Okay? Clear? So blood supply is easy. It's very easy. You just have to know the order of the structures. Duodenum, ileum, and no, this is foregut, midgut, hindgut.
What anastomosis?
So it is done. And there is an artery that connects all. We call that the artery of Drummond. Just answer 6 questions. Now, Right. Now the rectum, remember that the inferior mesenteric, after it gives the sigmoidal, changes its name, becomes the superior rectum, right? Why superior?
Because it's up.
Because we will have middle and inferior. So the rectum is supplied by superior rectal, which is continuation of the inferior mesenteric, and it will be supplied by middle and inferior rectal. Middle coming from the internal iliac, inferior coming from the internal pudendal, which is branch of internal iliac. I. So how hard is this? Superior, middle, and inferior? Hard? What are the arteries that supply the rectum? Superior, middle, and inferior. Hard? Alhamdulillah. And they come from?
inferior mesenteric.
Inferior mesenteric, internal iliac, internal pudendal. But I'm not really after the arteries. I want you to memorize this because when we talk about veins, I'm going to say veins that drain the rectum and anal canal are superior, middle, and inferior. Superior goes to inferior mesenteric, which is portal. Middle and inferior go to internal iliac, which is systemic. Right? Common sense. Right? So what is the story of the portal circulation? Portal circulation, portal vein is the vein that is formed behind the neck of the pancreas between two veins. This splenic and this superior mesenteric. Okay, so superior mesenteric and splenic, they form the portal vein. This vein, inferior mesenteric, drains into splenic. I want you to memorize what are the veins that will drain into the portal circulation. Basically the veins of the stomach. Right? So left gastric, right gastric, left gastroepiploid, right gastroepiploid, short gastric veins, plus the main veins that will form the portal circulation, superior mesenteric, splenic, superior mesenteric, inferior mesenteric. Don't memorize in the wallahi, this goes to the portal, this goes to the splenic, this goes to the superior mesenteric. For now, khalas, I'm not going to ask you about that. But I really want you to know the veins that will drain into the portal circulation, right? And I'm not going to ask you to name them. Again, it's going to be a stupid question, right? You're going to tell me left gastric, right gastric, this gastric fluid, left gastric fluid, short gastric, superior mesenteric, inferior mesenteric, and pancreatic duodenal. No, I will ask you something like, if I want to do portosystemic anastomosis, and connecting the portal with system, I would do this by connecting the left gastric and right gastric, right or no? Why?
Because they're
Both portal. Okay, I might say I will connect the left gastroepiploic and splenic. Both are portal.
Yeah, both of
Superior mesenteric and inferior mesenteric. Splenic and renal.
no.
Renal is systemic and splenic is systemic. This is what I want, right? The question is to connect systemic with. There's going to be something like this. Right? So make sure you guys memorize the branches or the veins that will contribute to the portal circulation. كم صاروا؟ يعني تقريبا. طيب. Fine. Now remember this. Remember this. We said the arteries of the rectum: superior rectal, middle rectal, inferior rectal. Superior rectal comes from the inferior mesenteric. Middle rectal and inferior rectal, they come from internal iliac. We're going to apply this to the veins. So if I ask you what are the veins that will drain the rectum and the anal canal, you're going to tell me superior rectal, middle rectal, inferior rectal.
Yeah.
Superior rectal is going to drain to inferior mesenteric, which drains to
Splenic.
portal. Middle rectal and inferior rectal, they're going to drain into the internal iliac. Right? So anal canal, that tiny little portion, 4 centimeters, has two systems that will drain it. One portal and one system. Now remember, the upper half of the anal canal has these mucosal folds. We call them anal columns, or we said mucosa is elevated because we have veins underneath. We call that internal hemorrhoidal plexus. And I did ask you, do you guys have internal hemorrhoidal plexus or hemorrhoids? You said no, but in fact it is yes. These are the branches of the superior rectal vein. They go into the mucosa, into muscles, submucosa, and they sit underneath the mucosa, right? But the middle and the inferior rectal veins, they don't even reach the mucosa or submucosa. They remain outside on the, between the muscles and underneath the skin. We call that the skin. We call that the external hemorrhoidal plexus, okay? But not only that, do we have communication between the superior and the middle and inferior? Yes.
Yes.
That is the portosystemic anastomosis. Remember, number 1 was the lower third of the esophagus.
Yes.
The second one, the
Number 2 is
Umbilical, anterior umbilical wall.
الأنا.
this anal canal, right? Between the tributaries of the superior rectal and middle and inferior rectal. And number 3 is
Umbilicus, anterior
around the umbilicus. We have a vein. No, I'll come to that. But first, so so did you understand this about the rectum and anal canal? Now remember, this is the portal vein, divides into right and left, and then it keeps dividing. Then eventually you're going to have sinusoids or cavities filling the blood, and those cavities, liver takes whatever it needs, and then the blood has to go back. It goes back because these sinusoids, they form central veins, bigger veins, bigger veins, bigger veins, and eventually you're going to have 2 or 3 hepatic veins, right? These hepatic veins, I said you will never see them because they, as soon as they come from the liver, they will enter into the inferior vena cava. Okay?
Yes.
Now, I said we have 4 locations where you have portosystemic anastomosis.
Yeah.
Now, why it is important to know that we have 4 sites of portosystemic anastomosis, and you need to memorize that.
Because if we have a cancer or a tumor,
If, for example, we
What's the fourth one?
block the portal system at one point,
I think
then all of the blood is going to go to the
I don't
stomach,
know.
which will cause varices of the small veins.
Good.
Because they're gonna die.
And those veins will rupture.
Yeah.
Now, if you have blockage of the system, any of them, whether portal or cable, for example, if you have cirrhosis of the liver, تشمع الكبد, or cancer of the liver, you will have signs of portal hypertension. Portal hypertension increase the pressure in the portal circulation. So those tiny little veins communicating between the portal and the cable, suddenly they will receive a huge amount of blood. They become dilated, varicose, and they might rupture. If they rupture, you will have bleeding. One of the sites where you have portal systemic anastomosis is the esophagus. If these veins rupture in the esophagus, patients will come to you with what? Vomiting blood, hematemesis. So also they will have ascites, accumulation of fluid in their abdomen. What else they might have? People with cirrhosis or liver
For
disease.
example, Caput's medusa.
I'll come to that. Other than this, jaundice,
Yeah.
yellow discoloration of the clear. Why? Because of elevated bilirubin. Okay, but one of the common signs is that they come to you with bleeding, vomiting blood. Okay, why? Because we have four locations where you have portal systemic anastomosis. Number one, we spoke about it earlier, which is lower third of the esophagus. It is drained by inferior phrenic, goes to inferior vena cava, and it is drained by left gastric, goes to portal. Do they communicate with each other? Yes.
yes.
If you have portal hypertension or disease of the liver, these tiny little veins that we don't see them, suddenly they become large and varicose and they might rupture. The patient will come with bleeding. Second site is actually around the umbilicus, on the anterior abdominal wall. Okay? We have a vein that runs in the falciform ligament, we call the para-umbilical vein. It goes to the left portal. But it communicates with the branches of the inferior epigastric, which goes to the cable system. These veins, they will dilate and they will become like spider legs. It's called caput mediosa in Latin, like this. So you will find around the umbilicus, dilated, congested veins. These are the veins that connect between the para-umbilical vein and the inferior epigastric vein. So this is site number 2. Site number 3, you already know it. Anal canal. Anal canal, the upper half drains into portal. Lower half drains into cable. Do they communicate with each other? Yes. You might have varicose veins there. Is this the same as hemorrhoids?
Yeah.
No.
Hemorrhoids is basically these veins here. They lose support and they come down.
Yeah.
But I'm talking about the veins that connect these with these. This is the portosystemic anastomosis. You don't see them. You will never see them. Unless there is...
Doesn't the varicose cause hemorrhoids?
No. Varicose has nothing to do with hemorrhoids.
So in that case, because each varicose in each location, they have a name.
Yeah, varicose veins in the lower esophagus. Varicose veins in the...
Because I think it was called esophageal varix, the one at the
esophageal varices.
varices. Yes.
Plural for varicose
Yeah.
veins, okay? Varices.
Doctor, for example, if there is cirrhosis of the liver, how do we know if there's Caput's medusa or the esophageal varices other than the symptoms?
You see them. Caput medusa you see in the anterior abdominal wall.
Yeah.
Esophageal, you need a scope, and it's very dangerous because you might cause bleeding with them.
But in cirrhosis, wouldn't they block all the portal system so all of this would happen?
Depending on the severity, yeah. Depending on how severe. But anyway, just keep that in mind. Let's not get into medical
Correlation.
stuff too much. No. For now, you should know just the basics. Okay? And the fourth, of course, is retroperitoneally. We have the bare area of the liver. It drains into the portal circulation, but it also drains into the phrenic and internal right thoracic in the chest veins. Also, the splenic and the pancreatic veins, they drain portal طبعا, and also they communicate with the left renal vein. Splenic and colic veins, they communicate with lumbar veins. These are the sites of portosystemic anastomosis. Okay, so make sure you memorize them.
Any more questions?
بيجي
We're
سؤال.
done. I already gave you 8 or
No, no.
9 questions with 70% of the SAQ. What else do you want? Other 30%? Other 30% probably you can guess without studying. Anyway, my point, blood supply is easy. We made it easy. You don't need to spend too much time. If you attended this lecture, I think you have memorized already 70%, 80%. Don't spend more than 15-20 minutes on this lecture and you will be fine. If you spend more, it means you're studying too much.
Doctor, what about the word that you gave us for this lecture? It has a lot of information. More than
No, it doesn't have a lot of information. It's whatever I said is there. But when you translate this into text, that's why, it's better to send a voice note rather than type on WhatsApp. Okay? Because in 1 minute, you say what you need to type like pages for text. Any other questions? Yeah.
Doctor, the ileocecal artery would have 4 branches or 3 branches?
See, this type of studying too much. Ileocolic will have from the inferior division, and I'll be more specific. We'll give you appendicular, we'll give you colic to the cecum, we'll give you ileal to the ileum. Things I did not focus on. No, from the ileocolic, the most important is appendicular artery. Okay? That comes that supplies the appendix. Right, good luck on your exam and see you with CVP. Unfortunately, I'm going to teach you with CVP. But, unfortunately for